patients. Time and the amazing work you're about to do, okay? Because you're going to spend long hours, so I want to thank you ahead of time. This is only the beginning, but I am grateful, okay? So good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. I'm your chairman, Jocelyn Pena-Milnick, joined by my vice chair, Bonnie Cowlson. I kindly ask for your patience if we encounter any technical streaming issues. Please set your electronic devices to vibrate. I did that myself. As a reminder, there's no food or drink allowed in the gallery. If you see us with drinks, it's because we sit here for hours. Sometimes, honestly, the members don't even have breakfast or lunch, and they're working through it. We need to keep hydrated, otherwise we'll be in the hospital. And this is a committee where it's health, right? We shouldn't do that. Anyway, for each bill, we're going to hear from the bill sponsor and the sponsor panel, followed by an all in-person witnesses. So just as a reminder, it will be for those of you that are new, favorable with amendment, or unfavorable. Then all virtual witnesses, because we are doing virtual as well to make sure that people have access to their government offices. If there's a large number of witnesses, I will alternate between favorable and unfavorable to try to have some balance and to be fair, to give everyone a fair chance of being heard. And for all of us, including myself, we don't need 20 witnesses to say the same thing on a bill. Try to be thoughtful when you choose your witnesses so they don't repeat themselves. And guess what? There is chocolate for those that say me too here in this committee. The bill sponsor testimony in this committee is not limited, but try not to abuse it, okay? While all the witnesses have 2 minutes to provide the testimony, but you can also provide written testimony, and we read it, okay? We are very thoughtful and considerate as well. A timer is displayed on the screen and on the witness panel, and a sound will play when your time has expired. Please adhere to our usual committee rules of 1 question and 1 answer, and please keep your questions brief. Members of the public will be able to view the live stream of this hearing on the Maryland General Assembly website and YouTube. And please remember that now, this year, and it came out of this committee and experience we had last year, we have closed captioning. But the closed captioning, well, it's not a but. It's a blessing to have it. It does pick up side conversations, so just be careful. And be aware. And we have a wide shot camera for the room as well. The videos now display your name, your district, similar to the House floor video. Today, we're going to hear the bill hearings in the following bill order. We're going to start with the first bill of the year, lucky you, House Bill 170. And followed by House Bill 54. So we're going to start with House Bill 170, and it's Maternal and Child Health Population Health Improvement Fund use. Good afternoon. If you could tell us your name, your position, and then just talk to us.
Good afternoon. Thank you very much. Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is John Crom. I'm the Executive Director of the HSCRC. One second.
John, we are having a
we look great. Oh, there we
go. Okay.
Great.
You were saying John Crom, but it was the ceiling.
People might prefer to stare at the ceiling than stare at me, but really appreciate the opportunity to express strong support for House Bill 170. The bill ensures continued funding for critical maternal and child health programs in Maryland, only using existing funds, not requesting additional money. I will let my colleague from the department, Laura Goodman, speak to the specific programs, but I'll give a little bit of context for the funding and the uses here. So under Maryland's total cost of care model, the state has set a number of ambitious goals to improve health outcomes related to severe maternal morbidity and childhood asthma. The HSCRC approved a set of programs led by Medicaid and the Prevention and Health Promotion Administration, FIPA, within the Maryland Department of Health when a fund was created back in 2021 through the Budget and Reconciliation and Financing Act. These programs were specifically selected for their alignment with the state's maternal and child health goals under the total cost of care model, and the dedicated funds approved by the Commission can't be diverted to other programs or uses. To date, the HSCRC has allocated $40 million to support maternal and child health interventions led by Medicaid and the prevention and FIPA. This funding was collected through a broad-based uniform hospital assessment and is currently set to sunset on December 31st, 2025. HB 170 just proposes to change the sunset provision to sustain and expand these essential programs and allowing the department to utilize the funds balance through December 31st, 2027. We project a remaining fund balance of $24.1 million at the end of FY25, with less funding available in the account by the current sunset date, December 31st, 2025. We're confident that these programs are on track for sustainability, and to date, the department has implemented regulations, established necessary contracts, recruited workforce, and so forth to stand these programs up. I would also note that these programs were stood up during the pandemic, and so one of the considerations here as well is that was a particularly challenging time to ramp up these new programs. So if this bill passes, MDH intends to spend the entirety of the remaining fund balance by the end of 2027. These programs are essential in reducing health disparities and improving outcomes for Maryland's mothers, children, and families. Extending the sunset provision for 2 additional years allows MDH to continue to scale and sustain these efforts, paving the way for a healthier future across the state. So the Commission urges a favorable report.
Wonderful. Good afternoon, Chair Pena-Melnick, Vice Chair Collison, and members of the committee. My name is Laura Goodman. I'm Deputy Director of the Medicaid Office of Innovation, Research, and Development. And on behalf of the Maryland Department of Health, I'm thrilled to be here today in full support of House Bill 170. So the Maternal Child Health Population Health Improvement Fund supports the state's share of a suite of priority maternal and child health benefits in the Medicaid program, bringing access to needed services for Maryland families. And additionally, the fund does support programming by the Department's Public Health Services Administration as well. Together, Medicaid and Public Health have dedicated these funds to increasing access to quality prenatal and postpartum care services, as well as to improving infant and early child health. And the interventions were selected specifically due to their potential to address health disparities. So the services selected stand in support of both the total cost of care model and subsequent AHEAD model. They also align with the department's Women's Health Action Plan, and they serve in support of the governor's priority aids of the state plan, which is ensuring world-class health systems for all Marylanders. So the extension proposed by House Bill 170 is needed to continue this funding for another 2 years, as Executive Director Crom said. For the Medicaid program, this is particularly important because it allows us to draw down federal matching funds, essentially doubling our resources for these programs. If the fund were to be terminated without the extension being granted, we would need access to additional general funds to support the services, and again for Medicaid to draw down those federal matching dollars and bring them into the state. So in terms of the programs themselves, thousands of Maryland families have already benefited from them, with, of course, our projected to continued increased uptake over the next few years, and we do intend to spend down those monies. Preliminary evaluations of the fund have demonstrated improvements in metrics like severe maternal morbidity, birth complications, low birth weight, and admissions to the neonatal intensive care unit. So I'm happy to dig more into the programs should the members have questions, but at this point, I thank you all for your consideration.
For questions now from the committee. First, we have Delegate Morgan, followed by Delegate Rosenberg.
Thank you, Madam Chair.
My pleasure.
So thank you for presenting the bill and everything. Who are best person to answer the question? Legislative analysts just recently came out and said that Medicaid across the entire sector is about a $580 million deficit than a couple of years ago. So what would happen if this program, this bill just sunsets? What is the repercussions and effects?
Sure. So at this point, part of the agreement between Medicaid and the Health Services Cost Review Commission committed the Maryland Department of Health to sustaining these services following the sunset of the bill. So with regard to that, we are committed to continuing to fund, and hence my comment about needing additional general funds to support these services going forward if the sunset were not extended by the bill. In terms of the services themselves, as Dr. Crown mentioned, we have, the startup process of enshrining these both on the federal side and the state side. So these are in our Medicaid state plan, with the exception of one which is in a what's called our 1115 waiver. I'm sure you'll be hearing more about that in the coming weeks. They are also in COMAR in the regulations for the state. So there would have to be an unwinding if we were to discontinue these services.
Okay, but it's regulatory. A brief question, follow-up, Madam Chair. But those would be regulatory changes because this program didn't exist until after COVID. 22, I think it was when you had the funding for it. It was extended 2 years. So what did we do prior to that?
Sure, absolutely. So in terms of if you permit me to dig a little bit into the services themselves, for home visiting services, one of the 5 Medicaid programs that is funded through this, that was a pilot. So we were using a smaller amount of state general funds to support those services, and the fund allowed us to take them statewide. A new service is for doula reimbursement. We were not funding that before this, so this allowed us to extend that new benefit, which is in the subsequent legislative session passed as a mandatory benefit. So that one is in statute. And then for 2 of the programs, one is called Centering Pregnancy. It is a group-based prenatal care program. Another is Healthy Steps, which is a pediatric model for early identification and family-centered treatment of pediatric mental health. Those are programs that are already paid for. What this funding supports is it gives an additional incentive to do those extra investments into those more rigorous programs, which have shown to have some effect on health disparities.
Okay, thank you. Thank you, Madam Chair.
Thank you.
Delegate Rosenberg.
Perhaps 2 questions, so let me just do one first. What are the population-wise, where in the state are the families that benefit from this program?
I do have an evaluation in front of me, permit me that I have not committed it to memory. It depends on the program themselves. For the home visiting, I know that we expanded to 14 jurisdictions, and it complements programs that are already existing on the grant-funded side, which I believe exists in all jurisdictions. We're hoping to continue to scale those, and what that does is we developed it to mirror the grant-funded programs so that they can, in the local health department, for example, in those 14 jurisdictions, can extend those home visiting services to additional individuals outside of the Medicaid program by providing some additional funds. I have it broken down, I apologize, by benefit and not necessarily by full participation. So I'm happy to follow up with that question, but they are statewide in terms of our services. I'm happy to look through my paperwork and provide an answer or follow up at some point.
Follow up is fine.
Okay.
Thank you.
Sure
Thank
thing,
you,
sure
Madam
thing.
Chair.
I'll note that down for you.
And if I may, I usually wait. I know Delegate Johnson has a question, but I will ask it because it's related to Delegate Rosenberg. The fact is that the money that you have, you're able to draw from the federal government, in essence, doubling the fund, correct?
Correct.
All right. In addition to that, you have presently in Maryland, our population is a little over 6 million, and we have about 1.4 million people on Medicaid, correct?
Currently, it's.
Or more?
More, closer to 1.6,
Close to 1.6?
between 1.5 and 1.6,
Okay.
as I checked.
So, and it was higher during COVID, correct? Because people didn't have work, right? And they were able to qualify. So in addition to that, in order to qualify for Medicaid, a person who's a single person, their income limit, do you know what that is? And you probably, if you do, I don't want to put you on the spot. It's 1,732. That's 138% of the federal level. A year that is under $21,000, 20,000 and something. How many people can live with 20,000 after taxes? Less than that. If you have a child, the income, it's allow for one person with a single parent, which there's so many, with, a child or so, it's 4,000, a little over 4,000 a month, which is about 48,000 a year, which after paying rent and all of that, there isn't much for people to live, right? So these programs are to help the very poor in our community. And the services that you actually provide, such as home visiting services, such as centering pregnancy, such as the mom program, right? Which we know that, for example, the mom program is very useful for, in the communities of color, Black women die at a rate 4 times higher than white women, correct? Mm-hmm. And when you look at doula services now, because not everybody has access to a doctor, especially in the very rural areas of the county, we now Medicaid, this program is paying for that doula services, right? And then when you look at Healthy Step as well, which is a pediatric primary care program that helps everyone, all jurisdictions in Maryland. We have 24, if those of you that are watching at home, 23 counties in Baltimore City. That also helps all those populations, right? Mm-hmm. As well. Because we want healthy babies, right? As well. Thank you. Delegate Johnson, followed by Delegate Shalega.
Thank you, Madam Chair, and thank you for coming and going over this with us. So we're on the eve of a sunset. So can you tell me, why is it we have such a balance still in the fund? Are we not being robust about providing the services, or are we not making sure people know about the services that are available?
Mm-hmm. Mm-hmm. Sure, absolutely. So we did need to stand a few months to stand up some of the programs as new benefits, think creation of provider type and the regulations I mentioned, federal authorities. So that got us off. We launched 2 of them in spring of 2022. So we were already a few months into our, period there. And then, for the doulas, for example, is a great example of innovation in the Medicaid space where the creation, we got our Medicaid infrastructure in place, but kind of matching the robust requirements on both the state and federal level for program integrity with a new provider type that's not, they are purposefully embedded in the community. They're known to the community and trusted by the community, but they're not used to billing a health plan on a fee-for-service submission basis. So we are working and figuring out how to reconcile for that benefit in particular, which flexibilities we can deploy in Medicaid, which we have, to make it easier for more of the birth worker doula provider network to grow. And then I think once, and those are rolling out iteratively, and we're expecting an influx on that front. I think with some of the others, as Director Crom mentioned, we were within the COVID pandemic, and so certain services like home visiting, which we had started to plan out the expansion of our pilot, when these funds hit, we had further waves of COVID. So home visiting services were not necessarily something we could really dig into as quickly as we might have wanted to, for example.
Follow up? Yes, thank you.
Please.
Thank you. So moving forward, do you have a more robust plan for spending this money down and making sure those services are provided?
Yes, absolutely. So we have always been, many of these benefits are implemented through our managed care organizations and Medicaid, and we've had a really robust engagement with them, which we expect to continue to do and increase over the next couple of years to really make sure these services are fully implemented, and, utilization is, we see that increased uptake that we're looking for. We're also working on communications plans in terms of getting the word out, increasing the department's ability. We have toolkits for some of these that we've put out to the public to use and sent out to different stakeholders in this area. And I think that we will continue to increase our kind of push on, getting the word out from as we can and using different communications channels, social media, using our health plans, working with the hospital industry. A lot of these, I think, fall in line, as I mentioned earlier, with the priorities of the HEAD model. So, we have different venues that we are going to be looking for to increase uptake of these services by the Medicaid participants across the state.
Okay, just one more little. So as we've heard, these are lower income families. So does your plan are you going to be able to reach the lower income families?
As best we can. So we learned through the public health unwinding period that went through, as the chair mentioned, we had to, our roles swelled during the public health emergency. We weren't allowed to kind of renew anyone's membership and remove them from our ranks based on, new status. So we had to go through a year-long program where we had to get in touch with every Medicaid person to come back in and renew their health insurance. And we learned a lot from that process. That's the takeaway here, is that we partnered with any and all entities that we could to get the word out about a needed step for people's Medicaid benefit. And so some of our learnings from that are to think very creatively. We were in laundromats. We did hot spotting. We have all of those availabilities that we could take from this and really see which zip codes have areas of need and target communications out in that way. I think there's definitely some learnings we can take and apply for these benefits as well.
All right, thank you. Thank you, Madam Chair, for the
Don't ask a lot of questions, so it's okay. So Delegate Shalega.
Thank you, Madam Chair.
My
Thank you
pleasure.
for being here. I'm trying to understand the funding side. We're obviously, facing some very challenging times. So is there additional funding going into this, or is it just using what is in, let's just call it a savings account?
So I'm happy to start. So this was really intended to be a startup, as Laura mentioned. So from the HSCRC funding perspective, once this new funding is not being added to this, so this fund will be drawn down, and then our hope is that at that point these benefits are sustainable without this funding.
It's hospital assessment is how it was funded. There is not a continued hospital assessment?
There is not a continued assessment.
So this is
purpose.
like, quote, a savings account or a fund that had money there that you were not able to spend?
Correct, yeah.
And if it didn't get spent, would that money go back to the HSCRC?
It would not go back to the HSCRC. I think it would go, I can follow up with you.
And how much it is? Because is it 40 million that's in that account? Or just, I thank you for the leeway here, but we should be drilling down on how much all these things are costing. It says 40 million one place, 24 in another, but
40 was the initial amount.
24 right now.
And 24.
24 right now. And it's not going, it's just to use that. There's no added money to it. Really, there's no fiscal note except for what was there to begin with.
Correct,
And you want to continue to do that work.
correct.
You can go ahead, because I asked some questions, so you ask some more. Go
no,
ahead.
thank you.
But it's 24, Delegate Shalega. But the question that Delegate Shalega had about what would happen, please get back to her and the whole committee. You like to share, right?
Yes, I always.
Okay. She shares great cookies, so yes.
Yes.
Okay, so make sure that the whole committee gets the information, because it's a valid question. Delegate Gazzoni.
Thank you, Madam Chair.
My pleasure.
Just to close out that loop, the other key piece of that is that we get the match from federal Medicaid.
Correct.
For the 24, without having to put out any additional general fund money to get that. Okay.
That's correct.
Just wanted to confirm that. Thank you.
Thank you. I just want to point out, federal money is tax dollars. There is no free lunch. So just because we're getting federal dollars doesn't mean that that's not somebody's hard-earned money. Thank you.
No, it's a good point. It's hard-earned money. But this population, that they can come here and give testimony and advocate for themselves because they are very poor people in our state. You know, when I looked at the 138% of poverty level, and I looked at why my daughter just moved out, and she's not going to appreciate me sharing. She just moved out. She's living on her own. Her rent is $1,750 a month. She's a student. And she said to me, Mommy, I just got my electric bill. And it was almost $300. And she's like going nuts. So my husband and I last Saturday went to her apartment and we put plastic on the windows. And we changed the filter, and we're like closing the vent, and we're like, let's see what this month does. But it's so expensive. It really is. But thank you anyway. We really appreciate you guys asking the questions. I don't see any other questions from anyone. You have a blessed day, and thank you for the work you do, okay? This concludes the bill hearing on House Bill 170, and hopefully she won't see this video. Next, we have House Bill 54, and it's the Health Service Cost Review Commission Use of Fee Assessment Repeal of Sunset.
Yeah,
We see you again.
Thank you so much. Continued good afternoon. I'm also here to testify in strong support of House Bill 54. This legislation is really critical to sustaining the Commission's ability to meet really our growing responsibilities here, and in support of Maryland's unique healthcare transformation efforts, and to ensure high-value healthcare for all Marylanders. So a bit of background on the user fee assessment. HSCRC is an independent state agency, really responsible for regulating the cost and quality of hospital services, but also taking on a great deal of analytic work for the state. The commission is entirely funded through user fee assessments, which are capped at 0.1% of the prior fiscal year's regulated hospital revenue. The funds cover operational costs, our staffing, our contracts, overhead. What House Bill 54 does is just removes the sunset on this funding formula. This approach was really modeled off of what other agencies do, so agencies like the MIA, other regulatory agencies. It's been in place since 2022, and really what we're asking for here is just to remove the sunset so that we can be like those other agencies, but also continue our essential work without interruption. We're not requesting a change to the percentage, and it's important to note that the law requires us to only collect what's needed to cover actual expenses. So when less is needed, we reduce our assessments as we did from FY24 to FY25. And also we would still be subject to all of the budget and procurement oversight that state agencies receive. So why is this necessary? Well, really since 2019 under the total cost of care model, we've taken on a number of new responsibilities, analytic responsibilities. So we of course have our historical regulatory work on hospital rates and hospital quality. That work continues. We also now support a number of additional affordability, quality, and population health programs for the state. We mentioned the Maternal and Child Health Fund. Those types of activities, we provide a lot of both programmatic support as well as analytic support. We also have significant work on the near horizon. So we have been engaging in a process with our stakeholders to really re-examine some of our core financial policies within our state agency, looking at things like assessing, are we providing adequate access to acute care services within the state? Looking at things like, are we adequately funding shifts in volume as patients move across the state and demographics change across the state? These are really complex analyses and policies that we have to develop. It's done in part by request of a hospital industry that is growing in complexity as well, right? So they are facing a complex healthcare financing landscape that they have to work within. So we're being responsive to that. We're doing that work, and we're excited to be doing that work. Additionally, we have, and I would also note, these are not analyses, these are not policies that we can pull off the shelf. We're really required as an agency to, as Maryland has done in the past, really forge out ahead of other states in developing these methodologies, developing these analytics. So these are heavy lifts. Additionally, over the last few years, the General Assembly has directed HSCRC to look at other complex issues such as emergency department wait times, medical debt, trauma funding, and hospital facility fees. So again, really excited to be doing this important work, but they do require resources, staff, and analytic capacity. This is all before we even get to the AHEAD model. So the AHEAD model brings additional opportunities to the state, but will also require additional analytic work as well. If the current funding formula sunsets, our operating budget will be capped at $20 million in FY26. So that would already put us below the amount included in our budget this year. So it would really be taking us back in terms of our operating budget right off the bat, right? Removing the sunset really helps us align our user fee assessments with the growth rate of the hospital industry. So in other words, it's just kind of riding alongside the revenue of the hospitals. Again, that's an approach that's kind of tried and true in funding regulatory agencies. And then finally, what we're looking to do here, given the work that is required of us, is we'll be required to, as any agency, as any healthcare organization, identify cost efficiencies, right, to manage under that cap, under that 0.1%. We have been doing that. We are going to continue to do that. But what we really need is a consistent budget mechanism, formula, right, that remains stable over time so that we can do the planning that we need to do in order to make sure that we're able to hire, in order to contract, in order to do this work on an ongoing basis. That predictability is really critical, as you all know, when we let out contracts, when we do this type of long-term analytics, when we build data infrastructure. We have to do that over a sustained period of time in order to, one, get the price that we need, but also you don't want to build infrastructure and then not be able to use it, right? So that planning component is a really critical aspect of why we need this stability. So in closing, House Bill 54 is really vital to ensuring the continued success of Maryland's healthcare transformation under the total cost of care model, and then eventually under the AHEAD model. Our ability to regulate, innovate, and then address key healthcare challenges really depends on adequate and predictable funding. Without this legislation, we really risk undermining the progress that we've made in controlling costs and improving care quality. So with that, I respectfully urge the committee to give HB 54 a favorable report. Thank you for your time and consideration, and I'm happy to answer any questions.
And thank you for your testimony and your work today. I'm going to open it up for questions. Delegate Rosenberg.
Thank you, Madam Chair. Would the analysis, the end result of the analysis that would be funded by the passage of this bill, would that save medical costs in the long run and expand Medicaid expenditures?
Yeah, so we've had a pretty good track record of driving healthcare cost savings over time, right? And one of the goals of all of the analysis that we do is have better visibility to the drivers of total cost of care growth, right? So that we can bend that cost. So I'll give you an example, right? So when we look at some of the work that one of the major initiatives that we're going through today is we don't regulate physician costs, right? There's a regulated component of of hospital costs that we view very carefully, and that's what the regulated rates go to. That being said, we need visibility to these unregulated costs. So we're undergoing an effort right now to understand what are, in more depth, what are the physician costs that are that are being kind of driven by the hospitals, experienced by the hospitals. What is driving that cost growth? This is a national problem. We're trying to get visibility into it in a way that no other state has, right? That work is complex, but ultimately it helps us get to a solution where we can figure out, okay, how can we constrain future cost growth in a way that's still accretive to health outcomes going forward. So yes, in all the work that we do, we look at total cost of care. What are the key drivers of that total cost of care? What are the potential health outcomes related to that increased cost? And then what can we do about it from a policy perspective?
Thank you.
Thank you, Madam Chair. And I'm going to apologize in advance if this really doesn't have a lot to do with HB 54, but it does. But so in today's budget hearing, he made a point to point out, he said, we are offsetting some Medicaid costs to hospitals and insurers and increasing efficiency to a couple of different things. But then later on, he said, we're offsetting Medicaid costs. The FY 2026 budget proposed to increase the Medicaid deficit assessment by $100 million annually.
Who's he?
The governor, Governor Moore. He gave a budget hearing today.
Right, because we did, I didn't know, so if you could just be specific.
Thank
yeah.
You. Because they call, whenever they talk about decreasing Medicaid spending, but we're gonna offset it, which is always some crazy accounting trick that I don't always fully understand how they're going to do it. But I know that the HSCRC is obviously going to be involved with this, and I don't understand if that's going to go to rates. And when we're talking about 54 in your own budget, do you have any comment on what the governor was speaking to and how that affects HRCRC and how you now come into this budget of $100 million or reducing $100 million in the budget and offsetting? How does HSCRC see themselves helping to offset that $100 million to hospitals and insurers?
Gotcha. So I wasn't there, so I can't speak directly to the comments, but I can talk. I think we're speaking about the.
I'll share it with you if you like.
That would be great. But I think we're talking about the deficit assessment. So the way that works and the role of the HSCRC within that is that assessment is built into, or the vast majority of it is built into regulated hospital rates and then is assessed out, right? So this is something that, that we've done on a pretty regular basis, right? We make adjustments kind of over time as that dollar amount goes up and down, and it's basically spread equally among the hospital rates so that it doesn't hit any particular region harder than another, right? So it's pretty equitably spread across the entire system. Our role within that is that we essentially administer the adjustment to the rates to accommodate that.
Okay. Thank you, Madam Chair.
Delegate Hill.
Thank you, Madam Chair, and thank you, Mr. Crump, for being here. So the HB 54 would just remove the termination date altogether. Now, what the Hospital Association is saying is as we move into the AHEAD model, which, as you know, has them chafing quite a bit because I think that our current model has some issues that haven't been adequately addressed before we move into the next one. Their concern is that there's too much unpredictability to simply remove the termination date ad infinitum, and they're suggesting instead that we extend it for 2 years, and then when we have an idea of what our new healthcare system is looking like, we have an idea of what the financial status is of the hospitals, then we can talk about doing it for a longer period or getting rid of it altogether. What is your response to that request for an amendment?
So I would say that many of the things that I discussed, almost all of the things that I discussed are kind of irrespective of the AHEAD model, right? This is policy work that has to be done. To your point, Delegate Hill, the policies, the current policies have to be examined and added to and reworked. That is also, that is the work that I'm discussing here, right? So the analytics and policy development work that we do on a day-to-day basis, like that is not attached to the AHEAD model. The AHEAD model may increase some of that work or change our opportunities within that, but we have quite a bit of work to do, kind of independent of the AHEAD model. So the other thing I would add is many of the things that we're looking at. So for example, I mentioned we're doing work to understand access throughout the state in a more holistic way. That's something that's essentially going to create a framework that we're going to need to maintain over time, right? If we're building that infrastructure, we're building that data infrastructure to look at claims in a different way. We're building a reporting infrastructure for us to be able to report that out. That's going to stretch beyond 2 years, certainly. And the contracting that we're going to have to do and the staffing that we're going to have to do is going to stretch well beyond 2 years. Again, that's the AHEAD model creates opportunity for us to do that, but that is work that we have on our plate, essentially no matter what, right?
Thank you. Thank you.
Thank you.
Lega.
Thank you. Thanks for being here. Is the AHEAD model a federal program?
So the AHEAD model is a federal program. It's a multi-state program, but it is built off of the Maryland model, the current iteration being the total cost of care model that we've developed over the years. So it has many of, almost entirely built off of the state
Our unique model, but
built.
are the feds going to pay for AHEAD or are we paying for AHEAD?
So the federal government is providing two things within it, right? One is there is a small component of dollars for planning and so forth that the federal government's going to provide. But one of the major things that we had to preserve here in order to continue our model is that it waives us out of Medicare fee-for-service payment. Right. That does bring a lot of federal dollars to the into the state, and what it critically does is it ensures that hospital rates for Medicare beneficiaries is on par with and Medicaid beneficiaries is on par with commercial.
Commercial, yes. One more quick one, please, Madam Chair. So your budget looks like it's supported by an assessment or a hospital tax
Yes.
that pays for your budget, and it looks like your budget is 22 million?
Correct.
So we just heard House Bill 170, so that would essentially more than pay your budget for a year.
Many of the programs that we administer, I mean, yes, they're substantial. This is just our operating
Sure.
budget.
Yeah,
Yes.
that, just making a comparison.
Gotcha.
Thank you.
Delegate Collison.
Thank you, Madam Chair.
Sorry, Vice Chair Collison.
No, that's fine. I was almost going to turn my mic off. Thank you, Madam Chair. And so John, thank you for your work. I appreciate it. I think I just heard you say that the AHEAD model, it was created because of our successes in restraining cost of care here in Maryland. Now, we can all debate whether or not the cost of care in Maryland is good, bad, indifferent, whatever, but I know a lot of people who stay in Maryland because of the health care that we have here in Maryland. So, I think that I think it's fair to say we've done a good job and at constraining costs, but while providing excellent service. And one of the ways we've done it is through the work of the HSCRC. And that's a really important concept or thing to remember, because it is through that agency that we've been able to do that. You're asking for 0.1%. It's clear. It's not even 1%. It's 0.1%. So is it fair to say, without the ongoing funds, the HRC could not do its work, could not be as effective as we are now, and that ongoing work is on, I don't see a sunset for the HSCRC at all. I mean, I see it going on for many years to come. In order to continue the good work that it's done, the other thing, you can agree or disagree or tell me I'm wrong, is that HSCRC, the activities of the agency have evolved over time. And you, as you just described, you've picked up many more programs and projects that are providing excellent care and services to our residents. So I guess my question to you, John, is, am I right in saying that the future of HRCRC is ongoing, or in your mind, and that any constraints on your ability to be funded is going to dramatically affect your ability to do the things that have worked so well for Marylanders?
Yes, absolutely. I agree with that. Everything that you said. The 0.1% also, I would just remind folks, is like, that's what we currently receive. So it really is just, we're just trying to sustain what we're funded at, our funding levels on an ongoing basis. I also very much agree. These are functions that will exist for certainly longer than the 2 years, I think in perpetuity. From my experience, even before I came to this job, I did a lot of this work in other states. Every state is trying to get better visibility to total costs of care within their state. Every state is trying to get their handle on access and quality measures within their state. Every state is trying to get more sophisticated on population health outcomes. So I think these functions are going to be an important, really tentpole set of functions as we do the important work of improving affordability and quality in healthcare on an ongoing basis.
Thank you, John. Thank you, Madam Chair.
My pleasure. Delegate Riley.
Thank you, Madam Chair. So my question, thank you for being here and for the presentation. My question is there any kind of transparency, requirements in with the HSCRC and the hospital so that they understand what your spending is and the effectiveness of the program currently? It seems like with their letter, they're kind of like, don't understand. I mean, they understand that you're doing a good job, but yet are there transparency requirements that they have a record? Okay, they're spending this amount of money, they're using this amount of money on this product. Is there any data showing that it's working? So kind of like that. So if you could explain.
Great question. So we are held to the same standards as everyone else. So we go through a budget process. We do the budget reporting. We line item our budget the same as other agencies. So this is regarding the user fee. Our budget, especially in the last couple years as we approached this sunset, we couldn't over obligate, right, our costs. So our budget came in lower, and then we assessed less over the last 2 years. That's all reported out through our kind of budget process, right? In terms of performance and analytics, on a monthly basis, we report out a number of metrics around the performance of the system that we regulate. So that's done on a monthly basis, and then we do annual reporting to that effect as well. That's our core things, and then of course we have many reports on an ad hoc basis and on an annual basis for drill downs into specific things, right? And a couple of them I think we'll be back to brief on over time as well.
Okay.
So examples of that are like the trauma.
Can I have a follow-up?
Oh.
So I hear what you're saying, but so you're saying that during this time frame that you've been in existence, you've had this conversation with the hospitals, with the Hospital Association. Is this new to you, this letter? I don't know if you saw their letter. Is this new, or has this been an ongoing conversation that you have at these meetings and you either aren't listening or they're not, asking the right questions? Has there been any kind of unity there, or is there a conflict currently?
So I would say that we talk a lot with the hospitals. Right. We engage on a daily basis with
That's what I figure. So are you surprised of the letter, or?
So the letter is new to us. We typically don't hear a lot of concerns about our operating costs, right? Typically, what we work with the industry on more closely is on the outputs of our policies, right? So they are very engaged on our policy work. So hopefully that.
All right. Well, I would hope that you guys would continue to communicate, and hopefully you can work out the issues that they may have. Thanks.
I appreciate it.
Thank you.
Any other questions or concerns? Seeing none, I want to thank you for your patience and for the work you do and for being in front of us. As always, for the committee members, especially the new one, anyone that testified, once the testimony is done, they're also available after hours. You can email, you can call, you can text, and get information as well. This actually concludes the bill hearing on House Bill 54, and it actually concludes the work of the Health and Government Operations Committee for today. I will see you tomorrow, God willing. It is 3:01, so I hope you have a great afternoon and evening, okay? Thank you for your work.